Management of Rectovaginal Fistula, a formal medical podcast discussion based on the 2022 guidance from the American Society of Colon and Rectal Surgeons. Welcome to this formal medical podcast discussion on the management of rectovaginal fistula. In this episode, we will review the classification, causes, and recommended management principles for rectovaginal fistulas, while keeping the focus on the 2022 guidance from the American Society of Colon and Rectal Surgeons. A rectovaginal fistula is a distinct type of fistula involving an abnormal communication between the rectum or anal canal and the vagina. These fistulas may be classified by location as low, middle, or high. A low rectovaginal fistula has a tract between the distal anal canal, at or below the dentate line, and the inside of the posterior fourchette. A high rectovaginal fistula connects the upper vagina, at the level of the cervix, with the rectum. A middle rectovaginal fistula lies between these levels. The terms anavaginal fistula and low rectovaginal fistula may be used interchangeably. Rectovaginal fistulas may also be described as simple or complex. A simple rectovaginal fistula is usually low, small in diameter, measuring less than 2 centimeters, and is often associated with obstetrical injury or infection. A complex rectovaginal fistula usually involves a higher tract between the rectum and vagina, has a larger diameter, or is associated with radiation, malignancy, or complications of pelvic surgical procedures. The most common cause of rectovaginal fistula is obstetric injury. However, rectovaginal fistulas may also occur in the setting of Crohn's disease, malignancy, infection, failed colorectal anastomosis, anorectal operation, or radiation therapy. Because these causes differ, and because the surrounding tissue quality may vary substantially, treatment must be individualized. The surgical treatment of a particular fistula is influenced by the patient's presenting symptoms, the anatomy of the fistula tract, the quality of the surrounding tissues, and any previous attempts at fistula repair. These factors guide whether conservative management, local repair, tissue interposition, or a more extensive abdominal operation is most appropriate. Key guideline recommendations. Recommendation 12 begins with the initial approach to care. Non-operative management is typically recommended for the initial treatment of obstetrical rectovaginal fistula. This approach may also be considered for other benign fistulas that are minimally symptomatic. The grade of recommendation is a weak recommendation based on low-quality evidence. Classified as 2C. Recommendation 13 addresses acute inflammation or infection. A draining septum may facilitate resolution of acute inflammation or infection associated with rectovaginal fistulas. The grade of recommendation is a strong recommendation based on low-quality evidence. Classified as 1C. Recommendation 14 identifies the preferred operative approach for many patients. Endorectal advancement flap, with or without sphincteroplasty, is considered the procedure of choice for most patients with a rectovaginal fistula. The grade of recommendation is a strong recommendation based on low-quality evidence. Classified as 1C. Recommendation 15 discusses episioproctotomy. Episioproctotomy may be used to repair obstetrical or cryptoglandular rectovaginal fistulas in patients with anal sphincter defects. The grade of recommendation is a strong recommendation based on low-quality evidence. Classified as 1C. Recommendation 16 applies to recurrent or otherwise complex disease. A gracilis muscle flap or a bulbocavernosus flap, also known as a Marsh's flap, is typically recommended for recurrent or complex rectovaginal fistula. The grade of recommendation is a strong recommendation based on low-quality evidence. Classified as 1C. Recommendation 17 addresses fistulas caused by colorectal anastomotic complications. Rectovaginal fistulas in this setting often require a transabdominal approach for repair. The grade of recommendation is a strong recommendation based on low-quality evidence. Classified as 1C. Recommendation 18 concerns radiation-related or recurrent complex rectovaginal fistula. Completion proctectomy, with or without colonic pull-through or colonal anastomosis, may be required in selected patients. The grade of recommendation is a weak recommendation based on low-quality evidence. Classified as 2C. In summary, rectovaginal fistula management depends on careful assessment of fistula anatomy, underlying cause, tissue quality, symptoms, and previous repair attempts. Non-operative management may be appropriate in selected patients, while operative repair may involve endorectal advancement flap, sphincteroplasty, episioproctotomy, tissue flap interposition, a transabdominal approach, or completion proctectomy in more complex circumstances. Thank you for joining this episode. If you found this discussion useful, please like, share, and subscribe for more formal surgical education content. This is the Everything Surgery Podcast, where we dissect the extraordinary.